So you have studied Ayurvedic medicine and these years take a major part of your life. Once you become a doctor, you are committed to healing. And to be a great healer, learning has to become a never-ending pursuit in your life. So doctor, what are you doing to continue this learning?
A very warm welcome to all the doctors, students and practitioners for this Acharya Rasayana.
Learning experience for everybody, even for me also, isn't it? So there is no end for learning. So that's what actually I believe.
Today's subject you are given is psoriasis.
Clinical dermatology.
If you use Vamana on yourself first, then you will believe that it will help.
Spending few hours with a scholar is equivalent to months of time spent reading books. In the name of Acharya Rasayanam, we are bringing excellent minds on Ayurveda with rich expertise in clinical practice. The purpose of this initiative is to guide and uplift the confidence and clinical expertise of every Vaidya. There is a saying, if you cannot be a king, the next best thing is to become a healer, because you are changing people's life, and that is the power of a Vaidya. Acharya Rasayanam is a Ayurvedic practitioner's only CME program initiated by Sitaram Ayurveda's 100th year celebration through Sitaram Research Foundation. Sitaram started its healing journey in the year of 1921. Being a pioneer in Ayurveda, Sitaram extends the healing powers through a state-of-art GMP certified manufacturing plant, government approved R&D laboratory, super specialty Ayurveda hospital, and an NABH accredited Panchakarma retreat. By attending Acharya Rasayanam, you will get the opportunity to get valuable insights on clinical practices, various methods and techniques prevalent in the Ayurvedic medical fraternity from the best scholars. You will be receiving the show notes, certificates, webinar recordings, and the latest updates on your email and WhatsApp. To receive latest updates and newsletters, please send a text to 89434 41881. For more details, log on to our website www.sitaramayurveda.com. Acharya Rasayanam. Great practitioners invest in learning.
Good evening, a warm welcome to all of you. Today we are having our 160th episode of Acharya Rasayana, a series of CME conducted by Sitaram Research Foundation and Sitaram Ayurveda Pharmacy Private Limited. Today our topic is on malignancy, scope of Ayurveda practice. For the session, we have the eminent speaker, Dr. Muralidhar Sharma Sir, MD Ayurveda, Professor Emeritus, SPM Ayurveda College and Hospital, Udupi, Karnataka. Welcome sir, welcome to Acharya Rasayana. And today our moderator is Dr. S.P. Sridhar sir, MD Ayurveda, Senior Medical Officer, ISM Department, Kerala. Welcome sir, welcome to Acharya Rasayana.
Thank you.
And last but not the least, I welcome all the doctors who are present here. Thank you. Handing over to Sridhar sir.
Namaste and Charaspash to Guruji of a Guruji, Dr. Muralidhar Sharma sir. We are direct students of Dr. Ravishankar Parvaje sir, who is student of the legendary clinician that Dr. Muralidhar Sharma sir is. We don't need much of introduction about him, and sir is a great personality of few words, more action and most clarity. You will see that as sir will share with us more than 30,000 follow-up visits of cancer patients, and you have seen the screenshot of what we are going to get into. Dr. Ashmi, is my voice very clear?
Sir, absolutely clear.
Yeah, okay. I hear you very faint. Maybe it's a problem at my side, but just for your feedback to be known. So I think let us get into full action. Dr. Muralidhar Sharma sir, Charaspash, and most welcome. Everyone is more than excited. And with a due respect to your time and those who have gathered here, without any further description about you, which we all are aware, your level of greatness, as you will take us from knowledge to experience, to wisdom, to intuitive knowledge, to what we would call as, and I would call as for sure, supra normal or supra-human experience that you have had, which you were very great enough to teach me, share with me, and I have got your permission today that you don't mind discussing that here, which will come to that. The subtle knowledge and subtle experience and superhuman experiences that you have had as a clinician. So that we will be not exactly a cancer topic, but that doesn't matter. If I speak those experiences here, my sanity and my honesty would be hugely questioned and challenged. But when it comes from your own golden words, then I think it will go to a level of enlightenment and illumination to the audience. So, respected audience, dear audience, please be ready for something that you may have never heard from any clinician, but that will come towards the end of the session only. For the moment, we will get into the most important agenda of the cancer-related topic. Sir, we are all yours, and we are not waiting for anyone. We are all yours, sir. We are all yours.
Okay, thank you.
Okay.
I hope I can share the screen.
Yes, sir. The screen. Yes, sir. Perfect, sir. It is happening.
I hope voice is clear.
Yes, sir. Perfect, sir. Sir, perfect, sir. The
Okay.
voice and the slide, everything great, sir.
Okay. Thank you. Thank you for the introduction now, and thank you for the opportunity to be with you in the evening hours of this day. The topic given, which I am supposed to talk, is about malignancy and scope for ayurvedic practice. Let me clarify, I am not a specialist in treating malignancy, but I do have some experience of treating malignancy and a bit of the academic point of view. From the contemporary side, western side, the malignancy, about the malignancy, the history starts with the Hippocrates, who described in 460 to 370 BC, the term carcinos or carcinoma was described by him, which describes non-ulcer forming and ulcer forming tumors. So that's the historical part. Then later on, in 28 to 50 BC, Roman physician translated this into cancer. In the 19th century, the definition of a malignancy or neoplasm was abnormal, benign or malignant new growth of tissue that possesses no physiological function and arises from uncontrolled, usually rapid cellular proliferation, which has the main three important characters: independent, pleomorphism, and no termination. Now, but this definition has been revived year by year over years, and it's about the sequence of those modified definitions. I think we will not go into much of these issues. I will not waste much time as such. The point is, the definitions are modified regularly, and the latest most definition by the WHO, which is approved in 2023, is cancer is a generic term for large group of diseases. So, one point, cancer is not a single disease, it is a group of diseases which has certain common characters, and the other terms used are malignant tumors and neoplasms. One defining feature of the cancer is a rapid creation of abnormal cells that grow beyond their usual boundaries and which can then invade adjoining parts of the body and spread to other organs. The latter process is referred in as metastasis. Widespread metastases are the primary cause of death from the cancer. This is the latest definition of the cancer or neoplasm by the WHO, which is having almost, which is supposed to be a complete one. But again, there is a large number of these specialists who are now pushing in for a revision of this definition, and the proposed revision, which is not yet approved, it's under the process. The latest is, and possible maybe in a few years or maybe the next year, the definition may be reviewed, and maybe that the expected would be cancer is a disease of uncontrolled proliferation by transformed cells subject to evolution by natural selection. Now, the whole important thing which has to be noted is the initial definition, the older definition in 19th century was describing cancer as simply a new growth which is independent, which has, that's it. But now the latest is that the cancer is to be defined as something which has been escaped from the natural selection, which has not been under the control of the natural selection. So there is a paradigm shift in the understanding of the cancer by the definition itself, at the definition level itself. There is a significant change about the perception of the neoplasm. The latest, now I am just coming to the latest part. The earlier versions is not important. The latest part of the definition of cancer or understanding of the cancer is because of cells which escape the apoptosis mechanism. Apoptosis mechanism means any cell which is either not having the normal structure during the generation of the cells. Some of the cells may not be normal, or something like in the society, some are which are anti-social, or which who do not really go with the social solutions, or which may not have the normal ability to have the functions, something like the disabled as such, or cells which have already done their duty or have completed these functions, and they are at the end of the stage of life, they have to have a natural death, and that natural death process in the tissues is called as apoptosis mechanism, which is a normal phenomena to keep the tissues healthy. It's something like in the society, those who do not follow the social rules, they have to be kept away from the society, or those who are not useful to the society, they have to be removed. This is a natural selection, or rather it is the other way also, jatasya maranam dhruvam, anything which is born which has to have the death as such. So it's a natural process of the death which is existing in the tissue. Now, if somehow that natural process of the death of the tissues which are not really useful, if it is not occurring, and if some of the cells escape this, now these cells may escape at any level, maybe at the time of the generation itself or the division itself, some of the cells may escape this due to any reasons, or some of these cells may escape the rule maybe later on during their course as such. They become abnormal growth, and this becomes what we call as the carcinoma or tumor pathology. Neoplasm would occur at that level. Now, the latest theories about the neoplasm, there is a major shift of the theory towards the immunological mechanism and that apoptosis rule than really something which is earlier it was believed to be something which is related to only the cell behavior. Now, genetics is one of the major issues, defects of mutation. As the cells mutate, there could be some of the cells may be mutating in abnormal manner, and that abnormal cells may escape the normal rules of apoptosis, and they may result in the neoplasm. Or it could be that during the activity of the cells, the receptor signaling pathway functioning of those cells may become abnormal, and they may escape the normal rule or normal natural selection rule. Or it could be like the cells may become less susceptible to the physiological functions of the changes in the environment, and they may not really function or relate to the environment, or the environment in the cells would be having such a situation where there could be a impaired balance of the protein utilization in those cells, or it could be due to increased expression of certain of the functions of the cells as such. All this would be resulting in a dysregulated apoptosis, and the malignancy would occur. Now, this paradigm shift in the theory of cancer, neoplasm, also is reflecting on the therapy aspects. So that's about the current theory. And earlier, again, when we were studying in the 80s, the definition of cancer or identification of the cancer was based upon only the histopathology. Now, because of these newer issues or newer information coming up, the diagnosis of cancer is also based upon immunohistochemistry, that a combination of the immunological principles and the genetic theories, they are coming up into the rather mainstream of the understanding of the cancer, malignancy, and the treatment also. Now, so all that concepts which are present about the neoplasm, they are depending upon the technological tools, starting like simple microscope for the histopathology, to the current level where immunohistochemistry and tumor markers etc. are used as such. So next question comes in whether there is a issue of description of the cancer pathology in Ayurvedic text or not. I am very sure like Sushruta or Charaka or any of our Ayurvedic Acharya would not have described the tumor pathology, neoplasm, in the same language or same manner as in the contemporary system because they didn't use a microscope. But the phenomena was understood, and the phenomena of having a dhatu, process of the formation of the dhatu in an abnormal manner where the pathological changes would continue into the generation of the cells, it's described in the context of the this process of the Bhedavastha. In the Shat Kriya Kala, the issues are mentioned in Sushruta. Kramena Upajayam Prapya Dhatun Anugata Shanihi Nashakya Unmulitam Vruddho Vriksha Ivamayaha Sasthirattvatu Mahatvacha Dhatu Anukramanacha. That Dhatu Anukramana, that's a process where the next generation of the dhatu would follow these abnormal qualities of the previous dhatus which have been affected, and hence it will be resistant to all the treatments. So that phenomena probably is described in the context of the dhatanukrama, and once it reaches to that level, it becomes yetesham avadirnanam ranabhavam apananam shastakriya. So probably in the shastakriya kala, bhedavastha, the changes which are described could be suggestive of the neoplastic changes. But as such, the pathology of the tumor pathology, as we see now, may not have been described in Ayurvedic texts, quite possibly. Now, but whether these diseases were understood in Ayurvedic context or not, the tumor pathologies definitely yes, they can be understood based upon the descriptions which you see in the Samhitas, and for that I would be classifying the neoplastic conditions which we see into their clinical presentation entities. The clinical presentation of neoplasms could be classified as mass lesions or lesions which produce obstructive symptoms, lesions which present with ulcerative lesions, lesions which result in hematological changes like leukemias, lesions which present systemic signs which produce also metastatic complications. These could be the maybe in brief these presentations of the tumor lesions, neoplastic lesions as such could be classified into these groups as such. Of course, there could be a few exceptions to these also, but a majority, almost all the tumor pathologies in the conditions, their clinical presentation can be grouped into these. Now, these clinical presentations are described in the Samhitas with the different names as such. The tumor lesions are presented as a palpable mass lesions, and the palpable mass lesions are described, I am quoting from Sushruta, Gatra Pradeshe Kvachideva Doshaha Sammuchiraha Mamsam Abhipradusha Vrittam Sthiram Mandarujam Mahantam Analpamulam Chiravurdhi Apakam Kurvanti Mamsopajayam Tu Shofam Tamarbudam Shastravido Vadanti. A swelling which is palpable and which does not have a termination on itself and which is presented as a firm immobile swelling, that's exactly the clinical presentation of majority of or maybe large number, I won't use the word majority again, large number of the tumor lesions on the surface of the body. They are maybe considered as the arbuda. So, of course, in the colloquial language, the arbuda is used as a general translation for the tumor, which I don't think that it is a very apt translation. Arbuda is related to the palpable mass lesions of the tumor variety, which are fixed and which do not separate. But the other lesions, which can also be now diagnosed as a tumor lesion, can be diagnosed with the Ayurvedic methodology, could be like a patient who presents with a mass in the abdomen or within the viscera of the body. Among the masses which are presented within the body and described in the text are, in case of the gulma, a case of maybe the carcinoma of the stomach, where it may produce a mass, palpable mass in the abdomen, viscera as such, may be considered as a gulma. Or the tumor course, one of the important course of the tumor is a non-separative course, which doesn't really separate. Now, such of the conditions which are described in Sushruta are mainly related to the again gulma, where that feature is described as napaka mayanti kafadikatvat medo bhuktvat visheshatsu doshasthirattvat dasanatretesham sarva arbudanyeva nisargatastu. As well as in the arbuda as well as gulma, the paka doesn't occur. The paka doesn't occur in the gulma because of mamsa shonita bahulyat pakam gacchati vidradhi. Mamsa shonita hinatvat the gulma pakam na gacchati. Gulma doesn't undergo separate because of its presence in as a pathological entity limited to the area, and the arbudas, they do not separate by their nature, by nature itself, and there is a entity called a dosha grathana. That dosha grathana is a phenomena where the changes are irreversible. They cannot be, the changes which have occurred are irreversible. Of course, one of the important nature of the neoplasm, as we know till now, is that changes which are produced in the neoplasm are irreversible, with a few exceptions. Again, in the current situation, there are some exceptions to that also. That's about one of the things. Now, some of the tumor pathologies which we see, like which may present in the obstructive lesion, like maybe a esophageal tumor, where the major presentation would be swallowing difficulty. Such of the obstructive lesion may be described in Samhitas as such of diseases which can affect the movement, normal physiological movement of the contents of the body. As an example, I will quote Balasa. Balasa eva ayadam unnatam shopam karoti annagatim nimarya tam sarothaiva aprativarviram vivarjitiyam valayam vadanti. Valaya and Balasa, the two of the conditions which can present with a presentation of dysphagia, where the food cannot be swallowed. And that also could be one of the possible ayurvedic diagnoses in a case of esophageal tumor. Or it could be many of the surface ulcerative lesions, where the lesions will be presented with a chronic, raised, fragile surface. Now, such of those conditions are described in the character of the Dushtapranas. Some of the Dushtapranas which present with the Ativivrata, Bhairava, Utsangi, Amajna Darshanagandha, Dirgha Karanbandi. These are all the different characters of a ulcerative neoplastic conditions. And hence, what I would say is, though the exact pathology of the tumors in terms of the histological changes are not described in Samhitas, these clinical presentations of the diseases were present at that time also, and they might have been diagnosed by acharyas under any of these heads as such. And the ulcerative lesions again, which result in a hard nodular ulcer which do not separate, we have to be treated by the lekhana. So such of the ulcers which are having kathina, stula vrutta, vosta, these also could be such of those ulcers which might have been identified by Sushruta as a specific entity which could be presented as a tumor, or a patient of tumor may be diagnosed as a Dushtavrana with that specific character as such. Or the other systemic symptoms as a presentation, like majority of the tumors would present with the systemic symptoms like anemia, emaciation as such. Now these systemic symptoms are described mainly in the Raktaja Arbuda as dosha pradushta rudhiram sirastu sampidya sankochya gatastu apatam sasravam unnashyati mamsapindam mamsam kuraihi achidam ashurdim. A proliferative lesion presenting with the polyp-like appearance. That's the typical feature of many of the particularly adenocarcinomas, and they tend to present with the bleeding complications. Hence, they present with the srabatyajasram ruziram pradushtam asadhyametad ruziratmukam syat raktakshayopadro pititatvat pandur bhavetso adbhuta pitirasto. So that could be the signs as such. Or the systemic disorders like leukemias, where the mass is not really felt, but they are classified as neoplasm. It's not the palpable masses, they are not tumors, but they are neoplastic conditions, malignant conditions like leukemias. They might have been considered among the category of asadhya pandu, dhatukata jvara, or blihodara, etc. Or the metastatic principles, the presentation of the metastatic lesions, they are clearly described in Sushruta in the form of Adhyarbuda or Dirarbuda. Adhyarbuda is described as Yajayate Anyat Khalpuro Jate, Jayam Tadadhyarbudam Arbudajnihim, Yadvanda Jatna Yugapat Pramadva, Biradbudam Tatya Bhavet Asadhyam. So asadhya conditions where the lesions may occur simultaneously or the lesions may occur after a certain period of time having the same character as the primary, they are described in the Samhita as such. And the principles of the treatment, like the tumor pathology, the successful removal of a tumor lesion is possible only when you for a complete total excision. And that's one of the major technique by which the outcome in the tumor has been changed in the course of the time as such. And that kind of a principle is mentioned in Sushruta as Sashesha Doshani Hiyo Arbudani Karoti Prasyasu Punarbhuvanti Tasmad Asheshani Samudharet. The arbudas need to be removed completely, where even a small portion should not be left over. And if at all it is left over, it can result in a recurrence as such. And if at all there is a complete removal is not possible, that the residual lesion, they may have to be removed either with the Krimibhakshana, formation of maggots, or maybe cautery. So that need for the tumor excision is there. Now, okay, all right. Now I will not go much into the theory portion. Theory would be boring, but the point is only that much. Though Ayurvedic Samhitas may not have mentioned about the neoplastic condition per se in terms of the same definition as we do it now, the clinical conditions which are having presentation of the tumor, they are already described in the Samhitas, and majority of those conditions either they are categorized as asadhya or maybe krichasadhya. So a simple concept of the treatment, a single concept of the treatment for neoplasm from Ayurvedic point of view may not be possible. So something like an anti-cancer drug or something like a regime where all the neoplasms could be treated might not be possible from the Ayurvedic point of view. Though many people say that you have something yogas which are mentioned for Arbuda like Kanchanara Gugul. Yes, of course, we do use Kanchanara Gugul in large number of tumor pathologies, but it's for only the mass lesions, where lesions are presented in the form of a mass. In other conditions, we need to bring in a line of treatment which would be corresponding to any of these conditions, and the sadhya lakshan, that something which is curable and something which is not curable, that prognosis is depending upon the clinical features of those conditions, and hence a thorough understanding of the Samhitas or view of the Samhitas in the light of what we see now is necessary. Now the point is, there is a lot of progress in the current situation, in the present day situation. There is a lot of technological process in the area of oncology. It will not be possible to cover about that progress now. And there is a significant claim that the outcome of the cancer has been changed, and maybe people always say that the cure for a cancer is within the reach. This is what the impression is. And in the society also, there is general feeling like the contemporary system treats the cancer better and the outcome of the cancer is better. Of course, I am not denying that fact. So there are definitely, yes, there are many conditions which are having a significant paradigm shift in the outcome after the recent developments. But in total, whether there is a real progress in the cancer treatment or not, let me clarify. Now, I am just highlighting only the one aspect, like the real outcome is not so good or not as good as presented. But at the same time, when I say this, I am not denying the other fact, there is a significant achievement. Now, from a Ayurvedic practice point of view, a practitioner's point of view, this issue is one of the sensitive issues. When a patient comes to you, they are, I would consider that way, when a patient comes to me, I have to decide like whether that patient has to be treated with our Ayurvedic principles, which do not have a specific targeted description of the tumor pathology, or should we adopt the contemporary system, or so on. So a lot of issues are there. I will try to deal with what I would deal with that. But to have that kind of an impression, we also have to have a clear idea of what the contemporary science gives in and what is the current situation in the treatment of cancer. Now the question is the world really making a progress against cancer or not? Now I am just showing the data, and the source of the data, this majority of these, whatever I am presenting in the next few slides, are from the authentic source of the data, our old data, which is a very authentic source of the data from all over the globe, and I am not adding anything. The only thing which I may do is certain of the things may be highlighted. I may change the color of this to highlight that, and I may stress upon certain of the points. So if and my purpose is not to offend anybody, and again I will clarify, my purpose is not to degrade the achievements of the contemporary science, but I am like trying to put the facts in a proper manner. Now, as per the data, in 1990, 5.8 million people died from cancer all over the world. In 2019, the data from that official source, you can refer to this data on your own and then reconfirm the issues. 10.1 million died from the cancer. So people who died from the cancer has increased almost by 75%. Number of cancer deaths have increased by 75%. But at the same time, the population of the globe also has increased, and if it is adjusted to that, the population growth, considering the increase in the population, the death rate from cancer has increased by 21% in the past 29 years, or 1990 to 2029, something like 2 decades. And it's always a claim that the rather technological progress in the last 2 decades is enormous, and lots of information has come up, lots of new theories of treatment have come up in the oncological practice, and there is a claim that there is a paradigm shift in the outcome of a tumor treatment. But the fact says the other way. There is a real increase in the death rate due to the neoplasm by 21%. The changes in the cancer outcome worldwide by 2000, it's up 1990 to 2009, the same figure given in the sequential events, like year by year sequential events. It's not, the cancer deaths have increased and the cancer death rate is also increasing by 21%. Age standardized death rate compared to the ages, like particularly old age, they have a higher chance, and if statistically this is corresponded, maybe you may say that there is a improvement in the sense the survival period of the cancer is more. That's the one issue. Situation in India. Now this data again from the same source, all the data are from the same source of world in data, and situation in India also is not much different. Now you compare these two graphs. Now I think the change in the graph curvature or the movement of this axis is not very significantly changed. Now I am comparing this to the global data and the status of in India. India is something like in the category of underdeveloped countries. Maybe again that point of argument is whether it's progressive developing or underdeveloping is not the issue. I am not going to that debate part, but in general, as far as the medical facilities are concerned, India is considered something below average, and most of the times the data is presented as if in India the death rate is more or the facilities, medical facilities are lesser than optimum. Whatever it is, the pattern is almost the same as that of the globe. There is not much of a difference in the rate of cancer deaths in India. Percentage shift is also almost on the same line, slightly more or lesser, so not much of a deviation. Now, cancer death rate by type, now this is another of the important point. Certain of the tumor pathologies, they have now changed, their outcome has been changed, and now this part I am just trying to focus on what we see in India. Global data of course also on the same line, but there is a slight difference as such. As far as the current data from again 1990 to 2019, the cancer death rates of breast cancer, cervical cancer have reduced, whereas the death rate due to the tracheal tumor, colon and rectum cancer have increased. See, in the 2019, the number 1 position was stomach cancer, then the breast cancer was in number 3 position. In the 2019 data, the breast cancer has been pushed to fourth position, so it's almost in the same position, fourth position. Tracheal and bronchus tumors have come to the first position. Stomach cancer has been pushed to the third position. Otherwise, the net rate of the outcome of the different varieties of the tumors almost are the same. In total, there is a change, but that change is not very significant as such. Now, compared to that, the same issue, cancer death rates in the United States in the long run, over the long run, again from the same, almost same duration, this is from 1930 to 2012, 2011, not exactly the same year duration. Again the fact is same, which is a very advanced country, and for all medical facilities we look at the United States of America as the benchmark standard. And many people, and particularly there is a general notion that if you go to the Western countries, you will have better treatment and better outcome. But if you look at the total data, the comparison of the death rates of different tumors as in 1930 to the present day situation, changes are not very significant. Yes, few of the lines show a downtrend, but tumors like lungs and bronchial pathology, breast tumors, they are not really reducing, rather they are increasing. The tumors like leukemia particularly, there is a significant downtrend in the leukemia. Leukemias have a better outcome compared to the tumors of the lungs. So in total, the net rate is not really having such a progress. And in the USA, particularly in the USA, which is now I am just taking the example of USA because it is considered to be the most advanced country in terms of the medical facilities, and majority of the pharmaceutical policies are decided by the USA, where you have established a system of FDA and CDC, and there one of the major programs in 2016, which has started as a Cancer Moonstar 2020, where the newer concept has come up in the treatment of malignancy. See, earlier to that, the general earlier notion, which is also still existing in the management of the tumor, is to kill the tumor cells with the cytotoxic drugs. Drugs which will kill the cells would be the preference earlier. But there is a change in the paradigm shift in the total approach to the treatment. And as in case of, as in the beginning I discussed about the understanding of the tumor also, there is a shift in the understanding of the tumor from a unknown factor to the immunological mechanism. So vaccine based immunotherapy is given a push, and lots of immunomodulatory drugs have come up, and with that immunomodulatory drugs they are claimed that there is a change in the outcome and the predicted outcome. This is about the expected number of patients living with the metastasis by 2040. Now, with all that newer inventions and that the current these outcome studies based upon that, the possible expectation from compared to 2010 to 2040 in certain varieties of tumors like metastasis of the lung, metastasis of the bone, and metastasis in the liver, or metastasis to brain. Controlling that, particularly immunotherapy is focused on preventing the metastasis, mainly the target. Of course, it also has a target of treating the primary, but preventing the secondary is the major area of the immunotherapy in the cancer. And the whole idea is, if you can remove the tumor by a safe surgery, and then the immunotherapy is followed up, the chances of recurrence are lesser. The safe surgery has been again become much more safer than earlier because of the newer technologies like computer assisted surgeries, laser beams, and so on. The newer technologies have added to that. The surgical technique has become safer, and you have the newer additional drugs by which the possible metastasis is reduced, and the prediction possibly by 2040 the level of these could be reduced. This is what is expected in the contemporary science about the tumor. Now, survival for after the cancer, this is another of the issue. In the present, from again after the diagnosis of tumor, how many patients have survived for 5 years? Generally, the general rule is A 5-year survival in case of cancer is considered as one of the major benchmark where we can consider that you have achieved a significant breakthrough in the outcome of the cancer. And the survival throughout the globe, global survival possibility of the 5 years cancer based upon the type of the cancer, particularly the survival rate has really significant in the prostatic cancer, it's by nature, whereas comparatively it's in the pancreatic cancer, the survival rate is lower, in between the other tumors as such. Now, the possibility of the people, particularly certain of the tumors, like in certain areas, there has been a significant change in the outcome of the tumor. Among them, breast cancer is one where the outcome has become changed drastically compared to 1990s to the present situation. The complications which are produced to the breast cancer have been significantly reduced, and the survival rate has been increased remarkably in case of the breast cancer throughout. Of course, this data is from England. Almost throughout this graph particularly is from a source of data from England, but throughout the issue it can be the similar reflection can be made out. And so in India, again, the survival rates by cancer type from 2009 to 2000, sorry, it's from 2009 to 1999 to 2009. Of course, this data survival is a bit older data. The maximum period, the latest period as per this data is 2009. In the last 15 years, again, there may not have been a much change, slight change, but the survival period in the breast cancer, prostate cancer have increased. There is a real increase, and in the stomach cancer it is increasing, whereas in some other conditions like lung cancer, it's not really showing any increase as such. So all that point is that the survival period and outcome are different for the tumor. Now this issue, though it's now some of you already might have felt that for an Ayurvedic practitioner, why all these data are necessary. These issues, they are necessary because when a patient comes for Ayurvedic treatment, we need to compare the outcome of our treatment with the global outcome or the outcome which can be given by the contemporary science. And one of the target of my treatment is a patient should not suffer due to my allegiance to a system. So that from that point of view, all this information is necessary, and that whatever I have given is simply bit of the information. It's only a small bit of it, but you need to be aware of all the current outcome as such. Now there is a bit another different view to the other part also. There is a significant change in the survival period of certain of the variety of the cancer, and the people claim that early detection and screening as one of the major breakthroughs or major essentialities for the treatment of, or which has produced a success in the treatment. Now, and there is a lot of movement. So almost stress is given for the early detection. Lots of technologies have come up for the early detection, and even in the National Health Program now, early detection of certain of the cancer is given a priority. So my purpose is not to undermine those values. So let me be again clear. I repeat the same. Like when I am putting a different view, it's not that I have a prejudice against the system, but it's about putting the fact as it. The fact is that whether this early screening of a general population has really helped or not. Again, some of these data are from the Western advanced developed countries than really in India, and the mammography has been established as, or maybe has been in certain of the countries, it has been a mandatory screening for people of population above 40 with certain guidelines, like who have a family history and so on. And that mammography screening since 1986 to 2000 as the data here shows, though there is a significant increase in the number of cancer detected. See, your screening might have detected the number of patients who have cancer more, but the real ultimate outcome is not that much significant. The real outcome is, if you look at the the outcome, the marginally the rate has been reduced. Success rate or survival rate has been not really increased as such. The again the success rate of invasive breast cancer and the metastatic breast cancer with all the screening program, effective screening program, because of the screening, that particularly the screening was introduced in USA in the span of between 80 to 90 during that period, and by that there is a number of patients who are diagnosed with the cancer are increased by around 30%. But metastatic breast cancer, the outcome has not been, this line has not changed. It's a fact which gives you a different sort of review. Now, by diagnosing a patient early, what happens? Now, this data is not again mine, so don't say that I have a prejudice. The data is from authentic peer-reviewed source from the Springer, which is considered to be very authentic, and this fact has to be very clearly understood. By diagnosing early whether you have really changed or not, based upon the large number of data, if large number of publications are there about these facts, the summary of this publication is suppose a cancer starts in the beginning and the patients are not diagnosed early because of absence of the technological tools, as happens in the underdeveloped countries, and the diagnosis is later only when the clinical presentation has become very conspicuous. So the total survival period after diagnosis would be lesser. Hypothetical patient, somewhere it may have been diagnosed at certain patient, they might have a cancer origin at some age as such. With the cancer origin and the development of a mass which can be identified. This again is a very interesting issue. See, cancer's origin, it starts at the first division of the cell. That cell which escapes an apoptosis, a single cell would be enough which has to have the cancer thread, this lifeline as such, or cell line of the cancer may be generated. Now that in the normal process, that abnormal cell will be killed rather, or damaged by the various factors like tumor necrosing factor and so on. If it escapes, it will undergo a division, and the tumor cell to be visible under the PET scan, the size would be minimum would be 0.2 millimeters. Only a tumor size of 0.2 millimeters can be identified by a PET scan. Sensitivity is a 2 millimeter. For a tumor to reach to the size of 2 millimeter, it has to undergo 10 to the power of 13 divisions. That's considered to be, of course, there is some newer data coming up in 2020, but up to 2018, the least size of the tumor diagnosed was 2 millimeter, and to achieve that 2 millimeter size, a cancer lineage has to undergo 10 to the power of 13 divisions. 10 to the power of 13 is 10 in and then 13 zeros. But how many crores, that's left to you, just do it leisurely later on. But in a situation where you may not have that kind of very sophisticated facility, suppose you are diagnosing only by the clinical parameter, and a clinical parameter, so by clinical examination, suppose you have to palpate a mass and then make out. If it's on the surface, maybe something like 1 millimeter, 1 centimeter could be that cutoff criteria. Or if it is in the abdomen or in the viscera, the cutoff size could be more. So imagine about the number of lesions which has occurred by the time you make a diagnosis clinically by palpating a mass, so on. But you might have been quite late by diagnosing the tumor at that delayed stage. But the patient would die by around the age of 70. This is again hypothetical. This figure is hypothetical. So the patient's survival period now has become shorter. Suppose you have used a technological tool, lots of advanced technological tool, and you might have been able to diagnose at an early stage. See, even there, you cannot diagnose a tumor at that stage. Still, it's not possible. None of the technology is able to identify a tumor at that stage where the first division itself has become erroneous. And you have the sensitivity of the tools might have been increased, and then you might have diagnosed at an early stage. So the patient may survive for a longer period after the diagnosis of the tumor, but the end will be almost the same. So the net advantage of early detection is not very significant. That's all the point. The only advantage is during this longer period, patient will be tagged as a cancer patient. Patient will be subjected to all that rigorous treatment of the cancer, and he survives that cancer treatment for the duration of the life. Whereas if you have diagnosed later, till this period, patient was not aware of the cancer, so he didn't have that stress of being diagnosed as a cancer, and then later he had some suffering in the life, and then that dies. The net advantage in terms of the expected life period is not significant by the early detection. Screening program has a limitation. Now, another huge data, another presentation which presents with the same issue. It's a huge data, again presented by a very well organized Saunders Company textbook as such, lung cancer with the CT clinics and chest medicine. You can refer to this as such, which is also a 2008 publication. Same issues, almost similar graph. The end results are the same. The lead time in the cancer diagnosis is the advantage given to the patient by early diagnosis. That times of having been tagged as a cancer patient is the advantage. The net advantage of the total life expected is lesser. And it's not only this, there are many such publications of different views, giving the different views, which give the same outlook about the limitations of the screening facilities. Those who are interested, they may read these references. I have just put the references from that point of view. So, my purpose of putting all these references is to again convince that I am not putting a prejudiced opinion, though it looks like. Say, I feel like many of you might have felt that I am putting a prejudiced outlook, but it's not a prejudiced outlook. And when I put these darker aspects, I am not denying the advantages of a contemporary treatment. So the now question comes in. I am not going to the details of what the contemporary treatment are, the protocols, so on. There are lots of complex protocols, guidelines, and so on. They are established globally and based upon a strong statistical build-up, and the results also are well documented. Advantages of these are still there, but still because of this, the global outlook on alternative system in the cancer management is increasing. If you look at the number of global publications, again peer-reviewed publications throughout the globe regarding these journal publications related to alternate system. I am not limiting only Ayurveda, throughout the globe, alternate system, and globally is the Chinese system documents, which are Chinese system presentations are more trends than really Ayurveda, but Ayurvedic publications also are there. In total, alternative system, the attention of the globe related to the cancer treatment of with the alternative system is increasing. There is a huge raise in the interest from 1990s to 2005. Citations of these articles in multiple publications also are increasing in the larger period. Now this shows about the total global interest about a possible alternative choice of the treatment in the cancer asset. Again, few of the significant publications, again reference of those who are interested, significant publications related to the alternative system treatment or complementary system in the treatment of cancer, which again, to use the word breakthrough may not be correct, which give a lot of impetus, which push in. So I have collected a few of them. Those who may see, who may are interested, they may refer to these articles, which are global. Again, now I am not putting these Indian publications, not the so-called simple journal publications. They are all high standard, well-acclaimed journal publications. From there I have just copied this, and these references you may be interested. Those who are interested, they may see these. Or similarly, from Ayurvedic point of some of the Indian publications, Ayurvedic medicine, some of those which have got a significant recognition, which have a higher number of citations, a polyherbal ayurvedic drug Indukantakrita, curcumin acid, overview on ashwagandha. These are certain of arsenic and Ayurveda. These are certain of the publications related to Ayurveda. So there is a global interest as such. Now, majority of these publications, there the protocol is Ayurvedic medicines or alternative system are used as an adjuvant or the adjuvant for the chemotherapy or radiation. Now, and many of these publications also have ethical questions like whether these alternative systems used are being justified or not, and there is always a visible prejudice over that. And certain of these acclaimed publications also, when they are cited in different articles, there is some of these issues coming up. That's about the global issues. And the scope of alternative system in the prevention of the cancer. Now, there is a huge scope there, and from Ayurvedic point of view, there is a huge scope. The guideline for prevention of the cancer published by WHO, which is considered to be the policy maker, I have just copied it. I have not added any single word, not changed anything. The advice of the WHO to help in prevention of the cancer would be lifestyle modifications of avoid tobacco use, maintain a healthy weight, eat healthy diet, exercise regularly, limit alcohol use, practice safe sex, get vaccinated against hepatitis, and so on. So again, I will not go into discussion of these, like how many of them are useful or not. Now, as far as the again data, the avoiding tobacco is considered to be one of the most useful, which has produced a significant change in the outcome of the cancers of tongue and oral cavity. And the diet and obesity is the other issue, which is closely related to the lifestyle. And the modification of the lifestyle in the cancer prevention is one of the major area of concern now. And it was in a year of 1996 that a huge publication, or rather a major research program was sponsored by WHO, and the whole program was food, nutrition, physical activity and the prevention of cancer. This publication was published, which has around something like 680 pages, huge publication there, which has collected about the information about the diet and the nutrition present in the global, throughout the nation, world, some of the countries' native system of food habits and their utility in the cancer and so on. Now, I have copied one paragraph of the same book from the page 168 page from the same publication. This is one paragraph I have copied, which relates to India and the interesting issue. Now, I don't think that I am talking about something which is diverse issue, but in that huge global effort where experts from all over the world have been added, and a few of the Indian specialists also, Indian so-called policy makers also were present, and very renowned these medical persons were in the team. A comment about the food habits in India. This paragraph is an eye-opener. Of course, there are lots of other issues. I am just putting one paragraph as said, without copying. The situation in India is described in that publication as, I would like to read it out. Since 1975, there has been a reduction in the cereal consumption, particularly coarse grains. Although this has not affected overall energy consumption, this is probably due to large increase in intakes of fat and animal protein, and also of milk and milk products in lower income households in India. Fat comes mainly from vegetable foods with very little consumption of animal fats, whereas in the highest income households, the majority of fat is from animal source. India is a major producer of vegetable and fruits, much of which are exported. So the nutrition and the food habits in India is criticized, and there is another one sentence which says that there is no national system as such of the food, or food system as such is not mentioned. In that book again, the impact of the nourishment or impact of the food over the different type of the cancer are classified, and a large number of cancers are noted where the impact is presented. Now, a very unfortunate issue is though the food habits in India are described with that current criticism, which is absolutely right. Like we consider as fashionable that having the food of that fat content and spicy food and so-called fast food, which is imported from the West. That culture is imported from the West, and we say we have a global food habit now. And that global food habit is one of the major reasons for increasing the cancer as such. If you go into the real idea of the food in India, it's a system of the food in India has been so developed, and probably you may not have any such a parallel example anywhere in the world at that time, where Anna is considered as a Ahamannam. In Chandogya Upanishad, it starts with the myself is Anna. Annadaham, Ahamevannam. I am the food, the whole source of the food is there. All whatever you think is or your personality is decided by the food. Whatever you are, the entity is the food. And about the restrictions and the vidhiniyamas, restrictions about the food and the guidelines, they are elaborate. If you go into our ancestral food habit system, even that position or location of the foods which are presented in the plate or in the leaf, banana leaf, we sit for the food, all these are the real health advantages. And whatever the Ayurvedic guideline says about how to take the food, like prasuste vinmutra hridi vimale doshesu swapatege vishuddhe cha udgare kshudupagamane vate anusarati tata agno udritte vishuddha karane dehe cha sulabha prayinjita aharam vidhiniyamidam kalassahi matah. Simple one sentence I have quoted about that. Probably if that is followed and if that is publicized, there could be a significant change in the outcome, in the prevention. Now, that's one part. Now, let me directly come into the clinical experience. Now, as I told in the beginning, I don't claim as an oncologist. I don't claim that I am a specialist in the management of the malignancy. But when a patient comes to me, a large number of patients do come to me for consultation at different stages. My boundaries, I am not saying guidelines, I am using my boundaries in treating the malignancy would be, or any patient would be, there are two important issues. One is a proper understanding of the disease with all the available technological tools. I would not hesitate to go into any of the investigations to make the diagnosis. So even though early diagnosis is considered to be something like which is not much of an advantage, I would not leave out, because that the contemporary approach, it has its own value, and we cannot just escape from that, because you will be compared from that. But the same idea is from original Ayurvedic idea, like Vyadeha Tattva Parijnana, Vedanayascha Nigraha. Though I may not be able to cure the disease, I will be trying to make the patient's life comfortable. That would be the target. A curing of malignancy may not be possible. And the basic principles of the medical treatment is of beneficence, non-maleficence, autonomy, justice, veracity and fidelity. All these have to be considered, and based upon that, I plan my strategy. And one of the other important part is life after the treatment is also important. Like when I say life after the treatment is, some of the protocols of the treatment in the current medical practice in related to the cancer would be such that the whole family of the patient would be on the roads after the treatment. And again, the end result may not be much significant. And suffering of the patient's family due to that burden of the cost, burden of this treatment may be unjustified. Now, I keep all these issues in mind, and I am just sharing some of my clinical experiences and some of the data. Again, it's not possible to give all the data as such. Now, as far as the direct curative treatment for the malignancy, generally, I would not go up for a curative treatment for the malignancy by own, unless I am very sure that whatever I do and the treatment is almost at the same line as that of the contemporary science. Now, as far as the surgical intervention, mastectomy, relatively more common type of the malignant surgery which I have done, mastectomy and the follow-up of these cases. Whenever I go for mastectomy, I would be preferring to go for only those who have refused to go to an oncology center are treated by me. and majority of the patients whom I have operated upon, they are at a higher grading, T2 and N1. T2 is a large tumor and N1 is where there is already secondaries in the lymph node. Complex outcomes, the general outcome is expected to be more worse. And majority of the cases operated by me were in the early 80s, 83 to 1995. After the 95, because the insurance has become a general issue and easily accessible, the number of patients treated, operated by me have become lesser. So majority of the cases whom I have treated at that range were of a poor category at that time, where the insurance facility was not available. And since 1998 the data. So majority of the patients whom I have operated were before 1998, but somehow I couldn't keep the data in a system. So after 1998 I could use the system, computer system for the data. So my data, whatever I am presenting, is a part of that which I have operated upon. So 37 operated cases after 1998. So 83 to 98, a large number of patients were treated, but I couldn't keep the data because of the absence of the facility, and at that time it was not considered as vital. So I have lost data. So I am just giving the data of after 1998, where the insurance has become more accessible and the number of patients are lesser. So malignancy, proved malignancy of breast, which I have operated, is something like 37. Number is not huge. And the outcome is I couldn't track up the patient for about follow-up of less than 1 year, is something like 7. Some of the patients now, once the surgery is done, post-operative, the patients may have been, and at that period, early period, that immunohistochemistry also was not so common. So majority of the patients, it would be only histological diagnosis and the treatment, like whether it is infiltrating or non-infiltrating, and then based upon that the approach would be that ERPR and the sensitivity to the hormones, that issue was not there at that time. These days, that also has become another of the important issue. So majority of these patients were at that period where the immunohistochemistry was not in vogue, and some of the patients who prefer contemporary treatment, I would always for the follow-up treatment, either chemo or radiation, either the patient may go for a contemporary, some oncologist, or some of the patients who prefer ayurvedic treatment, with the protocol or these numbers of patients, my follow-up, recurrence in 1 year, there was 10 recurrences. Recurrence in between 1 to 5 years, 9. Recurrence after 5 years, 2. And no recurrence with the follow-up of more than 7 years is 7. Now this data percentage cannot be compared to the global percentage because the number is less. See, out of 37 cases, the number is really not huge. But still, the outcome is almost maybe somewhat better than the global outcome at that period, in that range of 98 or early to this later 20th century, that part. Like after that 2020, the data shows some other shift as well. But and the major prescription in all these patients during the follow-up was Kanchana Raghugulu, and then some of the other medicines based upon the clinical presentation of the patients. Now that's one. Then the other varieties, again, of course I have treated many other surgically also. To put the data, all of them would not be possible. Now other spectrum of patients whom I have treated other than that of the surgery, of different varieties of malignancy, again from data of 2006 to 2022. So up to 2006, document maintenance was not such a way where I could retrieve easily, but now because of the computer I can retrieve the data easily. So based upon my computer entered data, in between 2006 to 2022, I have treated something like around 309 patients of new patients who have come to me, and on an average, this is average maybe 2.25 per day, and follow-up visits around 8.4 per day. So almost every day I see average of 10 plus patients of different stages of malignancy with different stages. Like Now, if I have to subgroup these patients, terminal ill patients, large number of patients who come to us for the treatment are terminal ill patients where they have lost all the hope. They have completed all the treatment, like somewhere else, either chemo, radiation, everything, and they come to a stage where are very huge metastasis, and they come to a stage at that where there is no hope, and at the end stage, either they may have completely exhausted their resources, they are not able to treat because the treatment given us is quite cheap, and or maybe when they have lost hope, I would usually use the word जिसका कोई नहीं है उसका तो SDM है यारो. So they when they do not have any this positive these visions, they come to us. Then another group of, and this comes to the majority, 8,237 out of 12,000. They are of that category who come to Ayurvedic, and probably the data may be different from other doctors. Other Ayurvedic specialists, they may have a different set of data. Their presentation may be different. My purpose of putting this data under this is how I strategize, how I approach to that. From that point of view, this data is important. And among my patients, majority of the patients are such patients who have reached to the terminal ill stages, and it's only about managing and improving the lifestyle. So that's the target as such. Then some of the patients are dropouts from therapy. Some of the patients may have undergone the chemotherapy or radiation contemporarily. Somewhere in the middle, they might have felt like they cannot continue with this because of many reasons could be many, and they may prefer to come for an Ayurvedic treatment. And some of the patients, they are undergoing therapy, they are ready to continue with the therapy, the contemporary therapy, they need some Ayurvedic treatment for backup, either to treat the complications, or they may consider this having an Ayurvedic treatment along with that may be beneficial. Then some of the patients who are diagnosed as malignancy, but before go for therapy, they come to us Ayurvedic treatment, and their number also is quite significant, and rather they want to have a second opinion. Then of course now there is a the issue is some of the patients, they have maybe a situation where they may come for, they have been diagnosed and they are not willing to undergo contemporary therapy, they want to have an Ayurvedic treatment, and some of the patients may come for a second opinion. And again, there is one group of the patient which is missing in the slide, like some of the patients whom I have diagnosed myself. So there is somehow that slide is missing. So a few hundred patients who are diagnosed by me as the malignant patients. Now, the strategies followed by me, considering all those issues of the safety of the patient and all the principles of the treatment, the patients who come to at early these late stages, ill patients, terminal patients, the expectation is low, and the treatment would be not targeted at adding to the life of the patient. Rather, I would say add life to the days. So I would not suggest adding days to the life of the patient, rather add life to the days. So somehow, whatever the patient is having the symptom, based upon that, you give treatment to make him comfortable. If the patient has bed sores, clean the bed sores, keep it clean. If the patient is having malnutrition, give some nourishment and maybe give Rasayana Aushadhis. Whatever is possible, the patient is having pain, some patient medicines which can relieve the pain. For the pain relief, I would prefer Gugulus, maybe any of the Gugulus depending upon the patient's condition. Selection of the drug, there is absolutely no specific drug for the malignancy. Depending upon the patient's presentation and dosha lakshanas, I would be treating that. Then the patients who have dropped out therapy, again I would give a judicious advice, preference, like if the continuation of the therapy would be definitely beneficial to the patient, I would advise the patient to continue. If the discontinuation of therapy doesn't produce a change, then my treatment prescription would be not again as a specific drug for the malignancy, it's about the dosha lakshana based approach, like depending upon the lakshanas, like vata, pitta, kapha lakshanas and the clinical symptoms. I would be planning a treatment, and major target would be to treat the Dharpagni, and usually my prescription would be Arogyavardhini and Kumaryasa was the common prescriptions in such conditions, along with maybe other drugs. Kantanara Gugul also may be given if there is a palpable mass tumor. Then patients who undergo these undergoing therapy and they have some symptoms like lack of appetite, weight loss, etc. Then again, my treatment would be targeting at Dharpagni, and the very common prescription would be Aragyavardhini and Kumaryasava, or other treatment based upon the presentation. Again, not anything specific per malignancy. Now, patients who are diagnosed with malignancy but not willing for undergoing treatment, this in such conditions to give an opinion is really challenging task. Now, to give an opinion, we have to have a very clear idea like what would be the outcome in the contemporary science. If the contemporary treatment gives a definite outcome, then definitely I would be pressing upon the patient for the contemporary treatment. If the results in the contemporary treatment is also doubtful, then whatever is possible we may treat, and in that condition I may prefer the lines of treatment like Arbuda, like Kantanara Gugulu, or maybe at times it could be like Rasamanitya, or at times it could be Bhalataka. So certain of those drugs are used, but again with Bhalataka I have found some limitations, like Bhalataka given in the form of Kshirapaka, Bhalataka Kshirapaka may help in regression of the tumor, but it results in bone marrow malfunctioning, and the high doses are given. Whereas the Bhalataka given in the form of Avadeha or other yogas may not have that significant benefit, whereas Kantanara Gugulu is considered to be a safe drug, but the outcome or the results which can be produced are not very significant. So at this stage, I may use some of the specific drugs which could be targeted for the tumor as such. Then when a patient comes to me for a second opinion, this again is a similar situation where they are ready to go for the contemporary system. In that condition, it's the same. And even for the patients whom I have diagnosed on my own, first time patients diagnosed by me, in that condition also the same issue is followed. The strategy is to keep that interest. Then a palliative care in the case of tumor is our area of strength. Majority of the patients, they can be managed in such a way that they act to the life, to the years. That's what I say. Many of those conditions they are incurable, and many of those conditions where the patients may have undergone the contemporary therapy or undergoing contemporary therapy in the first 3 doses. My usual prescriptions would be, again, I'm just putting that summary of the prescriptions. For the pain management, Niruhabasti is more preferable, depending upon the fitness of the patient. Then for the patients who present with the dyspepsia, it's Aragyavardhini and Kumaryasa is the usual prescription. Patients presenting with Ashwagandharishta, Cachexa is the usual prescription. TNS pyrexia, one of the common complications who have undergone chemotherapy or undergoing chemotherapy is the tumor necrosis induced pyrexia. Mrityunjaya Rasayana Amrita is the usual prescription. Again, the point directly is I don't suggest any specific treatment for malignancy. I don't have any anti-neoplastic regime. Rather, the treatment would be based upon the dosha condition of the patient. With this, there can be a satisfactory outcome. Now, about the prevention. Now, I just share one of that clinical experience. One of the family of the patient of a cancer breast, CA breast, they are well affordable, this family. Siblings of healthy siblings, now of course there is a typing error, it's not healthy siblings with a family history of breast cancer. See, that patient's family had a history of breast cancer to their elder sister, their mother also. Now, the 2 younger sisters at the age of something like around one is around 30 and another is around 35 years. They came to me in 2018 with this CA 125 tumor marker level at 70 and 82. In one patient it was 70 and another it was 82, and they wanted to have something by which they do not have the cancer. And now at this stage, of course, the number of patients who of that category are very few, and this is only two of the patients where I could have a regular follow-up. And in those patients, I have not given any medicine. I have not suggested any medicine. Suggested about the diet, lifestyle, diet, particularly no guru aharas, and the same protocol, like only after having the digestion you have to take the food, and none of the spicy food, no packed food, no preserved food. This has to be used. And lifestyle recommendations, regular exercise, pranayama practice is advised, and the patient was treated with virechana once in a year. And most of the times the patient would come to me somewhere in March or April because they have holidays, and so that seasonal Rutucharya and that virechana could not be followed as per the your Rutu, but because of the convenience we could do that. And almost every year they would have that tumor marker study, and the tumor marker has shown not a significant raise but somewhat a reduction. The tumor marker in one patient, the elder patient, where the initial tumor marker was 70 in 2018, and every year, of course, it's not exactly at a span of 365 days they have done it. They have done this test somewhere within that range, but they have done that tumor marker study every year. And with this follow-up, like virechana once in a year and diet and lifestyle modifications, there is some fluctuation in the tumor marker level, and it's at the range almost at the same range. Still, it has not come to the normal level. The normal level is less than 30, and there is a fluctuation. And important is till today, there is no evidence of lesion. Patients are otherwise healthy. So, but this data is not enough to put as a generalized notion. But I think the approach may be a guideline whenever you get such an opportunity to prevent. And those who follow this healthy lifestyle, healthy diet, they may not have this recurrence or having the tumor as such. So prevention role, diet and lifestyle, pranayama, I think they have a definite role. So I am not able to present an objective data in a large number. This is about two of the patients where we could record. Now I'll just to summarize, and then I'll give a few of the two cases, or rather two of the patients, again large number of patients where certain sensitive issues are to be considered. Now this is one patient, about a patient who came to me in 2012, 6/7/2012. She was 72 years old. She had been treated in KMC Manipal nearby and was considered as jejunal stromal tumor, and the patient was recommended for jejunostomy, and she was having all the clinical symptoms of intestinal obstruction, was maintained on continuous gastric drainage and parenteral maintenance. Now, and they were, by the time they were diagnosed and the treatment was suggested in KMC Manipal, the middle class family, they had almost lost the hopes, and they considered this as a hopeless case. And as usual, at that end stage, they considered this as end stage. The patient came to us on 2012, 6/7/2012. When the patient came to me, the patient was in a total this intestinal obstruction phenomena. Parenteral management was continued. I stopped the gastric drainage. That the patient was given IV nourishment. Dashamula Nirohobasti was given as usual for the pain relief, and Kantanara Google Arogya through rail tube was given intermittently whenever it's possible. Now, what I observed is during my regular rounds, a huge palpable mass could be palpated, and as I palpated and changed the position, it was freely mobile, like it's a somal tumor, quite large size, around 10 centimeter size. That tumor position could be just changed. Because of that modification of the tumor position, the patient would have a bowel movements. The patient could be passing the stools. By twisting the tumor to a position, patient could pass the stools, and for a day the patient was able to take orally. So rails tube feeding could be reduced, and we could feel that rails tube intermittently for acid. So this observation gave me some idea, like this patient can be managed surgically with certain some innovative technique. patient was convinced or patient was impressed upon the need for surgery. Initially, that old lady was not ready to go for surgery, and with this clinical this twisting torsion of this mass, I could keep the patient on oral feeding by around 10 days after 10 days of this observation, and I thought of this laparotomy, and the patient was impressed upon the need for laparotomy, and she gave consent for laparotomy on 7th, 8th of, or August 7th as such. After nearly about a month of admission in the hospital. During this period, I had given her IV fluids, maybe nourishment and so on, all that protocols to improve the general condition of the patient, and patient was fit for surgery. The patient was not ready for that enterostomy tube. See, standard surgery for the jejunal tube would be that jejunal tumor, somal tumor, the tumor would be excised, and then a feeding tube has to be put into the abdomen, and patient had to be fed through the tube. Patient was not ready for that, so I promised that I would not do that. So I will just open and see if there is an opportunity or not. This is the research summary from the Manipal hospital at the time of the admission. Now, I did the laparotomy. The tumor mass was quite huge, it could be seen, and very interesting issue. The treatment which I did was surgically, it could not be removed.
Mesenteric malignant. This is what we can't do anything. Both we can't do anything. Close. Then if you want to have a photograph.
And kept fixed over that, so
that was confusing. So,
there was no intervention except that repositioning and preventing that tumor from getting twisted, so that it would be in a fixed position, and in that fixed position it will not move. The patient tolerated well the surgery. Patient survived for quite a long period. For about 3 years, the patient had survived, and during these 3 periods, patient was being treated with the usual treatment, like of course Kanchanaragula was given regularly, Arogyavardhini also was given regularly. In between, depending upon the need of the patient, any other modification, Taxarista, maybe 1 or 2 blood transfusions also were given, but the patient was comfortable. The tumor was still persisting, tumor was accepted, the patient was of course having that palpable mass, and she was just came to a position where she would take it jocularly, and she would joke on like, this is my child. So she would be asking like, how is my child? Every time when she comes for the follow-up. And during this period, her granddaughter's marriage was then celebrated, and that in that marriage function, I was one of the person of interest. People were more interested in me than the bride and bridegroom. That's all the other issues. But the important is, patient had survived well, comfortably. She was doing all her normal activity, and in 2013 we had a conference on malignancy in SDM. Patient was presented live on that conference also. The point is, the patient had a absolute better quality of life, and the average cost of medicine prescribed and that patient is around ₹7 per day. And the patient expired in 2015. She survived for 3 years without any issue, and in 2015 she developed a stroke and then later complications, and she died. Now, standard guideline for a somal tumor as such would be radical excision followed by imatinib medicine. Imatinib is a immunomodulator continuously for the whole life. And as per the current data, the median survival period with this protocol of the treatment is around 10 to 12 months. Whereas this patient has survived for 3 years without that. And the current market rate of imatinib 400 milligram, of course, when I say this current market rate, this is around the rate in 2015 is around 3,200, but latest in 2020 the rates are reduced. Now the cost of 10 tablets is around 2,000. So the cost of daily treatment, if at all the patient had to follow, would be with imatinib at that period, where imatinib would be a bit costlier, would be around 2,000 rupees per day would be around the cost of the treatment, where the cost of the treatment given by us, our prescription was 7 per day, and the patient had a better quality of life. Now, by this again, I am not claiming that the treatment has really produced a cure or so on. The purpose of presenting this issue is, see, with our treatment protocol, we can produce a change, and that change can be compared to the contemporary issue and contemporary outcome, and you can have a better result, and maybe it may improve the quality of life. That's about the positive issue. The important is that okay, that's one of the important one of the cases which I have present, and the important issue is same. Our major strength is in the palliative care, and extensive descriptions of the clinical presentation of neoplastic disorders are mentioned. With this, let me conclude. Of course, there is another case which I would do. I wish to present, but somehow that slide is missing. The negative aspects of these issues. See, in 86 or so, I had a patient of carcinoma esophagus, and I did a gastrostomy, put a tube into the stomach, and then the patient was managed with the Kanchanargupal and Pallataka during that period. The patient's general condition initially improved because of the gastrostomy tube. The patient was fed on the tube. Patient was not able to take anything orally. A carcinoma of esophagus where there is a total blockade and a removal of the tumor was not possible. Now, that patient had survived for about 2 months, showing some positive outcome in terms of the weight gain and certain positive outlook. And the patient on some day asked me, like, can I eat a sweet, or can I put the sweet into the sweet which is called holige here in our area, we call it as holige. I don't know the Malayalam word for that. A sweet, favorite sweet which is available here. Can I put that into the tube and then take it? See, patient cannot take anything orally, cannot enjoy the food taste, but a human tendency to have that food which was emotional. So I was quite emotional, and from that day onwards I didn't do any these bypass surgeries or enterostomy tubes. I didn't do that. I stopped doing that. See, that the depth of the human emotions have to be considered. A patient who is not able to taste the food, but he would be preferring to put the food into the tube. Somehow on that day, I was a bit immature at that time, I would say. I said, no, you cannot, because then it can produce obstruction. That comment itself led to a depression. Patient became depressed, and of course all the other causes added on. And within a few days, within a week, the patient died due to the later on complications, sequence of complications developed. That's one of the emotional issue. Another of the emotional issue is about another of the patient, around 30 years young boy, who had an extensive tumor, huge tumor in the brain, and it was absolutely inoperable. And the patient had a totally bedridden, persistent seizures. Throughout the body he had the bed sores, and at that time he was only one son of the mother. And at that hopeless situation again, the patient came to our hospital, and the patient was in the Glasgow coma scale of around 8 as it, and the patient was treated with all the support treatment. The bed sores were treated with Jatya regularly, and I had given all nourishment supplements, and the prescription, of course I cannot say which is a single prescription. Some prescription was changed depending upon the patient presentation. Patient's mother was the only one who was taking care of the patient, a old-aged mother, 30 years old young boy, only one son of the mother, and he was just in the beginning of earning of the life, sudden development of these issues, and in a hopeless situation. The mother's only desire was just to make the patient again conscious and recognize her asset. And with all this treatment which I could do, that support treatment, none of the treatment for malignancy. Somehow the patient became conscious, his coma scale improved, and it reached up to around 12 to 13 something around. And the patient opened the eye and then recognized the mother and called Amma. And once that was achieved, mother asked me, somehow she said, now it's okay if he dies. I will be wishing that he now dies, and I don't expect him to live more. And of course, after a few days, the patient died due to some other complications developed. But when we deal with the cancer patients, these emotional issues, a mother expecting the son to die because she has seen so much of the suffering, and the only ambition of the mother is to see that the son recognizes her. So these are the issues which are really emotional and which we need to keep in mind when we treat the patients of malignancy. Now, my purpose of referring to these issues is not to show that all the outcome is great or so on, but which makes that approach to the treatment of malignancy very sensitive. Human issues are there, which we need to consider, keep in mind. And then, if you keep in mind, definitely yes, Ayurvedic treatment has a definite scope in the management. And from my point of view, our area of strength is the palliative care at present. A curative management of a tumor may not be possible at this stage. It may need to develop, and the Ayurvedic therapy for as an adjuvant again needs a standardization. Maybe a collaborative study may be necessary. With that, it may be possible. And prevention of the disease following the guidelines is which requires more focused attention as well as a social this awareness. With this, let me conclude, and probably I think I have put the point properly, and those who expected something like a specific treatment for malignancy may be disappointed, but I think I have put the perspective properly, and I would expect some of the questions from you. And of course, there was one request from Dr. Srijit about certain of the other experience. I think I will come to that part if all the this audience permits about it, and maybe if there are any questions, I will try to answer the questions, and then we will go to that part. Okay, Dr. Srijit will excuse me. Right. If there are any questions, I think if there are any questions, let me answer those.
So yes, sir, you may ask last time you did, because I think the role of moderator is negligible in your presentation. So I think as you did last
I'll
time.
go through that questions like some of the chat box. I think it's most of the chat box comments are very informative. Thanks and so on. There is one question: female cervical cancer patient with diagnosed since 15 years had undergone radio and chemo treatment, now unable to pass the stools due to rectal wall edema. Multiple lymphadenopathy in umbilical region with creatinine level is 2, vomiting 2 to 3 per day, no feeling hungry, and blood in stools. What would be the prognosis? Of course, the prognosis is poor in that case condition, absolutely, and definitely yes, we can do something to relieve some of the distress. And from my experience point of view, I would prefer to use Arogyavardhini and Kumariasav in such a condition where the patient's appetite and bowel movements may be improved to a certain extent. So that the treatment is purely to improve the quality of life, and that's it. Then there is another question like, is there any improvement in the quality of life with the early diagnosis of malignancy? I think I have put the data and I have clarified about it. Early diagnosis of the malignancy may not improve the quality of life, but there is a claim that the patient's survival period will be more, and I think I have put the data correctly with all the available resources. Right. Then there are any more questions? Sir, you mentioned Rasamanikya and refer to arsenic compounds in cancer care. Can you share? See, now with the Rasamanikya again, now I am not using that. Earlier, in the earlier stages of my career, I used the Rasamanikya. With the Rasamanikya, particularly in case of leukemias, it shows some response. The Rasamanikya given at the dose of 1 gram per week, it gives some response, but the effect is not long lasting. So now since around 10 to 15 years I have stopped using Rasamanikya. Earlier I have used it in a large number of patients, but it needs some more improvisation. The dosage and schedule needs some improvisation, so I am not able to suggest that. Then there is another question like Ayurvedic management of myeloproliferative cases. So again, I would not suggest any specific treatment for myeloproliferative disease, but based upon the clinical presentations, you may consider this. In general, I would consider myeloproliferative case as a Dhatugata Jwara Lakshanas. Their clinical presentation would be something like the Dhatugata Jwara, and without maybe with a specific input about the patient's data, the schedule may change, but I would be preferring to treat that patient with the Dhatukata Jwara Lakshanas, like Dhatukata Jwara Yogas. Maybe my common prescription would be Mrityunjaya Arogya Kumaryasava, or the patient may be even given Bastis, particularly some of the Niruha Bastis, which can be of Jwaragna variety. That would be my usual prescription in that condition. Again, I will not suggest anything like a specific treatment for the myeloproliferative disease as such. Then, right, then why Arogya and Kumaryasava are, I would consider the main targets of Dhatwagni. They are the drugs which can improve the Dhatwagni. Of course, any other Pachan, Deepan, Pachan Dravya can be used. My treatment, my experience is with these drugs because I have used in large number of patients. Pancreatic cancer, of course, I have treated a few of the patients. Surgery with the surgical outcome of pancreatic cancer is very poor. A patient presenting with a pancreatic cancer, the surgical outcome is very poor. Particularly radical surgery of pancreatectomy outcome would be poor. If the patient has an obstructive jaundice, I would prefer to have a bypass, this root-wise jejunectomy, so that the patient would have a biliary drainage. So biliary drainage, if it is achieved, the patient's clinical condition will improve, jaundice will reduce, and at that time, based upon the clinical symptoms, we can manage. And as I told you, the outcome is always poor, but quality of life can be better. After roots and jejunectomy, if I give Agni Tundi Arogyavardhini Kumaryasava, the diet, food intake would be better. Patient would have lesser amount of pain, and patient can survive for a longer period. And along with that, if the patient is having diabetes mellitus, then because in pancreatic cancer quite common, you may have to prefer Asanadikvata also. That's what I generally prescribe. And the outcome is definitely comparable to the contemporary treatment. I don't say that the patient can be cured. So the patient can be managed better, managed satisfactorily. There can be a definite positive outcome to the patient. That's maybe an answer to that question. Then what could be the relationship between hepatitis, papilloma vaccination and cancer prevention? Of course, the data is presented. Now, see, as far as prevention of the cancer and the data is available. So we have to depend upon the available data. As per the available data, that virus, vaccination against the virus, papilloma virus, and this HPV in case of cancer of the uterus also, these are now suggested as promising, and I cannot question that. See, I cannot question, I may be able to question only when I have a data otherwise. But as the other side of the data is not available, we cannot question. We have to accept as the data is available now. If we have something input which can definitely negate that, then of course we can question that. But at present, as per the available input, with the available input, I would not question that. So that may be considered as useful. Then how to decide at what stage of malignancy patient may be benefited from our treatment, sir? Now, for this question, the answer would be very complex question. Like, from my point of view, I think I have given my strategy clearly. I have explained that strategy clearly. My priority would be to keep all the basic principles of the medical beneficence to the patient. So whenever I suggest any patient to undergo my treatment or not, I would consider the possible advantages from our treatment, and this would be educated to the patient, and the contemporary system of the treatment, outcome of the contemporary system of the treatment also has to be known to the patient, and this we can guide the patient only when we are aware of the contemporary development. So again, most of the times I would say for a successful Ayurvedic practice, you should be more modern than a modern doctor, and you should be keeping abreast of the developments, the current data about the outcome of the tumor. So I am trying to follow up that. Every time there is a new input coming about the tumor outcome or guidelines coming about the outcome, I follow up and then keep that in mind, and considering that data and the cost of the treatment, available facilities and so on, I will try to educate the patient like which is better and which is the otherwise, and or maybe if the patient is not able to take the decision, I will be able to take the decision considering that beneficence principle, that the patient should be benefited, and then only we can suggest. So that question like how to decide at our stage malignancy, our treatment can be benefited. That principle of beneficence is quite important. I am not trying to keep my patient as a this guinea pig. But in a patient who is hopeless, like the one which I quoted, like about that Shantanayak patient where I did that unique surgery, the tumor was kept in a pouch. So it's not a guinea pig, like making the patient as a guinea pig. But you may have some innovative approach which could be case specific. So to generalize this answer would be difficult. So in that patient, because the outcome elsewhere would be very poor, you think of any of the options and then you may get something positive. Now, when I say about the positive, usually I will be presenting about the positive, but the negative issues also are there. The negative issues like emotional issues, failures, all these are there. So it's not that every patient you will be succeeding. So that question of which stage the malignancy can be treated with our treatment, the answer will be very complicated. So I may not be able to give a straightforward single sentence answer. The answer would be based upon clinical experience. You have to improvise. Maybe if you ask me like a few years back, what would have been approach and what is now, there is a significant change. See, earlier the approach was depending upon the experience which I had accumulated at that level. Now it's depending upon the level. Maybe after a few years, again my views may change based upon the clinical experience. So to give a very definite, clear-cut, black and white answer to that question would be quite difficult. But I think I have clarified the issues properly, right? Then there is another question. Please throw some light on Ayurveda Chikitsa in prevention of recurrence of metastasis of cancer. I think I have given my experience, I have shared my experience, like prevention of the cancer, even the metastasis. Now, to confirm whether our treatment has prevented the metastasis or not, for that the best thing is you have to know the correct incidence of the metastasis in that particular tumor in the contemporary outcome. Then in general, if I have to give a general brief answer, I would be always ensuring that the patient follows the proper guideline about the Achara Rasayana, that your healthy lifestyle. So particularly diet, the most important is about the diet and exercise. And it also has been proved, like diet and exercise can help a lot in the prevention of the metastasis. Then if you keep the Dhatogni proper, the chances of metastasis would be less. So usually my common prescription, again with a few exceptions, the common prescriptions in that condition would be Arogyardini Kumaryasava continuously, which can help the patients live better, and even the possibility of recurrence can be reduced significantly in majority of the patients. That's based upon my clinical experience. Then dosage of Arogyardini Kumaryasava. Dosage of Arogyardini, my dosage is 1 BD, 500 milligram tablets, morning and night twice. Kumaryasava 2 teaspoon BD, 10 ml BD. That's my prescribed dosage. Right, then there are informative sessions like can you highlight Ayurveda diagnosis and the management? I think for pancreatic cancer, it's a sort of gulma. Again, it's a sort of gulma, maybe the pitta gulma based upon the clinical presentation asset. So it follows that same principles of that gulma asset. Then myeloplastic MDS, low HB and male, how to manage and prognosis. Of course, myeloplastic conditions, again the outcome is poor. Patient needs to have a blood transfusion repeatedly. So blood transfusion is repeatedly followed. Then the bone marrow transplantation, the outcome also is poor. And I would prefer to keep the patient on Abrakabasma dosage, or maybe 1 gram per week regularly for infinite period, and the patients may have certain clinical improvement. I have treated a few patients with that myeloplastic pathologies, and of course patient needs to have a blood transfusion maybe repeatedly. When the hemoglobin goes low, need to have the blood transfusion. Then of course the rest of the things can be managed somewhat satisfactorily. Even that bone marrow transfusion transplantation has a very poor result in that. If the patient prefers, it can be suggested as such. That's one. Then noted incidence of cancer have taken significantly post-COVID. Now this again, all that fact we have to say based upon the data. Yes, of course, post-COVID the incidence has been increased. So the real pathology is not yet understood. Some people attribute it to the vaccination. There are some reports which say that the vaccination has increased the possibility of bone marrow related tumors like leukemias, but it's not yet confirmed. It's a controversy there. Right. Then there is another question like age of BRCA family patients who are taking annual variation and since how long being followed. See, I have given that follow-up. This follow-up is 2018. Since 2018, the follow-up is there. And the patient is, one patient is 32 years, another is 37 years at the beginning. Now they are 37 and 42. So still no final word can be mentioned about that issue, but till now 5 years they have not developed. Statistically, the possibility we can still now claim that, see, patients who have a family history and where the tumor marker CA125 is higher, the chances of having a malignancy at the age of 40 is around 70%. So this is based upon the statistical data. And these two patients have not developed at that stage, but it's too early to claim. So I am again saying that. But till now, they have not developed that evident lesions and they are otherwise healthy. Suppose the same continues for another 10 years. After 10 years, if the same is true with that patient, definitely yes, then we can claim that the treatment can be managed. Then again, same question, myelofibrosis, myelodysplasia syndrome management, the same thing issue. In the myelodysplasia, blood transfusion is one of the issue. Prostatic cancer, any Ayurvedic treatment. Again, I don't suggest anything like a specific, but I would consider this as a variety of Mutrakricha. And in a case of prostatic cancer, if a patient comes to me for a treatment, I would be preferring to have architectomy. I would not do the prostatectomy. I would do the architectomy. And I have a good number of patients where after the architectomy, the chances of metastasis has been reduced remarkably. And it's absolute true that by removing the testicles, which is a relatively simple surgery, the possible secondaries can be reduced remarkably. So I would not go for prostatectomy. And followed by that, I would be treating that patient with the Chandraprabha, Ashwagandharista or Kanchanara Gugulu. And with that, I have patients where the metastasis has not occurred even after 10 years or plus. And of course, in the contemporary system also, that kind of a data is achievable with the similar approach to the treatment. Then there is another question. See, bladder wall cancer management. In all these, now, none of these, again, don't expect me to give a specific answer like a specific drug regime for a specific management. I think I have stressed upon that point repeatedly. And same questions are repeated. Treatment for ovarian carcinoma, treatment for bladder carcinoma. I would always prefer to have a line of treatment based upon the dosha lakshanas in that patient, and it has to be custom made based upon the dosha lakshana. Then do you advise Daiva Vyapasya Chikitsa on CA patients? That depends upon the belief of the patients. If a patient says that Daiva Vyapasya would be treating or benefiting, definitely yes. Now I think that's exactly the point which Dr. Srijit also preferred to that. Now this Daiva Vyapasya and related issues, I would be probably Dr. Srijit was expecting me to share that issue. I am referring to a patient whom I have treated in 2006 and 2007, something around 2006. It's about a patient who had an obstructive jaundice, and she was diagnosed possibly as a tumor of the head of the this common bile duct, and she was the MRI done in other hospital had shown a soft tissue mass in the common bile duct with the CBD dilatation and obstructive jaundice. And some of the astrologer had recommended that patient like the patient has to be treated by me. And if the patient was in some other bigger hospital like KMC Manipal, and astrologer has told that if you continue the treatment in that hospital, you will die. Now that patient, of course, poor family patients, they came to me with these investigations, follow-up MRI image. And I looked at the MRI image, I felt that it's not a tumor, but it's something like a free-floating, maybe a soft stone, or maybe a blood clot. So I dared to open the abdomen, and I opened the CBD, and very interestingly, in that common bile duct, I could see a roundworm, live roundworm. Live roundworm was removed from the common bile duct, and I put in a T tube, and I was quite happy. Like, see, the outcome would be very excellent. A patient who was having expectation of a malignancy and then very poor outcome. And we had a very simple case of this roundworm in the tube. I was expecting the patient to recover very well. Of course, the post-operative period, everything else was fine. The only thing is the T tube which I had placed, I couldn't remove the T tube because once I closed the T tube, the patient had a leakage of the bile. And this continued for quite a long time. I tried everything under the sun there. It came to a level where I would be frustrated. Usually, he would be able to remove the T tube by about a week. In this patient, it continued for 1.5 months, almost 45 days. The issue was that patient had developed a common bile duct inertia, where the intraductal pressure was higher. See, normal pressure is around 14 centimeters of water, and in that patient it had gone to 40 centimeters of water. If I connect a saline bottle to the T tube and keep it at a level of 40 centimeters or above, there would be a free flow of the saline without any problem. But if it is reduced, then the this secretion would not flow. At that time, the treatment should have been a sphincterotomy. Sphincter had to be dilated with the endoscope. And at that time, during that year, we didn't have an endoscope. I got the endoscope later next year, following year. Patient was not ready to go to any other hospital for the treatment. The patient was insisting on my treatment, so I tried everything possible. Many times it went to the level of irrationality because every day a patient suffering even after 40 days after the surgery. It was a very frustrating experience, and it came to level where I could lose the sleep also. Now, with that kind of a pitiable situation, some fine morning, I got a dream, and in the dream I opened Charaka Samhita, Siddhisthana, 8th chapter, and I could see a Basti Yoga, which is mentioned in the Siddhisthana 8th chapter as Udavartahara Basti. So, and immediately as I woke up, I could see the Charaka Samhita, open Charaka Samhita, exactly in the same page, same location, the same yoga was there. So I copied that, and I got that Basti prepared with our Panchakarma department, started with the Basti. Interestingly, next 2 days, 3 days, that pressure, 40 centimeter water pressure came down to 14 centimeter. On third day, I could remove the T tube. Patient was discharged within 5 days after treating the Basti, and the patient was absolutely asymptomatic for next 3 years. And after about 3 years, patient met with a road accident, and at that time the patient was taken to Manipal hospital and she died there. So astrologer's prediction has become true. So Daiva Vipashaya, that's the other part, like whether Daiva Vipashaya or such of those which are considered as something subtle, whether they are true or not, whether they exist or not, that's the point as such. That's the point, one of the issues as such. Then any preventive ayurvedic treatment for being benign cyst should not be malignant later. Yeah, that conversion of a benign to malignant is also one of the important issue. And I would always suggest, like, see, one of the better treatment for all these prevention would be, if possible, we can remove. See, wherever it is possible to remove a benign lesion, that's a very sure remedy. So I would be preferring that. Being in the surgical stream, I would prefer to remove the mass, benign mass, if it is possible, or if it is not going to have a more collateral complication. That's more safer method of preventing that benign to become malignant. If this is not possible, or if this is not opted by the patient, then I would consider the same protocol like healthy lifestyle and Dhatogni, targeting about Dhatogni, Arogyodni, Kumaryasa as a better means of preventing the metastasis. Then every time requesting ask questions and Q and answer, and Sitaram team requested to take question. I think what I am not able to make out what it is like. Then 58-year-old lady patient recently diagnosed as mild leukemia, TLC 72,000, and mid-joint hip knee pain, mild splenomegaly, Ayurveda management, and see, in case of leukemias, particularly myeloid leukemia, the outcome with the contemporary treatment is excellent, extraordinary. 7-year survival period in a chronic myeloid leukemia is achievable in 85% of the patients. So, when a patient comes to me with the myeloid leukemia, with that limit like 72,000, with not much of a significant complication, I would always suggest the patient to undergo the contemporary regime than really trying with Ayurvedic treatment. So, that's exactly the point. Then there is another question like multiple myeloma. Ayurvedic correlation of multiple myeloma, I think it's again the Dhatugata Jwara, maybe Asti Dhatugata Jwara. Then can you please share treatment of chemotherapy side effects? Of course, there are huge issues. The major issues are, one is dyspepsia, hair loss, and then poor general condition, psychological issues, then tumor necrosis, fever, pyrexia. These are the major issues. Dyspepsia is the most important issue, and I would always prefer Arogyodhini, Agnitundi, Kumaryasava for the dyspepsia treatment. Tumor necrosis, fever, pyrexia, I would prefer Mrityunjaya and Amritarishta as a principle of treatment. These are the two major, very common issues with the chemotherapy. Then majority of patients may have depression, psychological issues. In that condition, Smritisagar and Saraswati would be a better tool there. Basti, again, the selection of the drug would be depending upon patient. For pain relief, it is Dashamula Niruha Basti which is preferred. If for the emaciation, I would prefer either Rajayapana Basti with Mamsarasa or Ashwagandha Basti, Ashwagandha Kashaya Basti is the preference. Then could there be any relation between increasing incidence of malignancy post-COVID? Again, a similar question is asked earlier. Then what's your opinion in total about resection of complete lymphadenectomy in the left side part of the right hand surgeon? Because I had seen relapse of left side only. Now, I am not getting the question properly. There is a question like, what is your opinion in total for resection of complete lymphadenectomy in left side part by left hand surgeon? Because I don't know, so I am not able to get the gist of the question, so I can't answer that. Anyway, I think there are no more questions, and so we'll wind up as such. Then of course, as per Dr. C's request about certain of the issues. Now, one of the important issue is we say practitioners, medical practitioners, as the one who can control the life and who have a command on the life. But all that is true only when we believe in something. Say, doctors, particularly Ayurvedic doctors, cannot be atheists. We need to be believers. We have to have the theist as it. So belief on something beyond your control is an absolute necessity. I would consider this as a safety valve in the pressure cooker. See, our field is something where you will always have a pressure, and this is necessary to have like a pressure cooker, safety valve effect like. And of course, lots of experiences. Everyone would have that kind of experience. But when I had some talk with the Dr. Sridhar, we had discussed some of the issues, and he wanted me to maybe share with all of you. One of my personal experience with this would be, it was in 2012 that I myself had a fasciitis. Pain started with the pain in the thighs. Initially I neglected. Then it's a fasciitis. So with the Kaishorokugulu Mrityunjaya usual treatment, I became better to a certain extent. Then again, I did not follow the basic rules of etiquette, like I did with overexertion, unnecessary as such, and this led to a acute pain. I had a acute pain on the some day, and very severe. Never experienced that kind of pain, and the whole psoas sheath was swollen, and the option treatment at that time was fasciotomy, surgical opening. So I was really worried. I had done fasciotomy of many patients, and that surgery is quite a rigorous one. And now I had to be subjected to that. So I was very depressed, like, and very interestingly, and that day when I was in the maximum peak of frustration, and night, I had a dream, and in my dream, my guru, Professor P.J. Deshpande, and one of the well-wishers of mine in Banaras, Pranape Gopalacharya, both of them, they came where really I could see them in the dream. And Professor P.J. Deshpande scolded me like, why you have this? And then he, in the dream, he inserted a needle and then aspirated the fluid out. And our Pranape Gopalacharya asked me to have Ganji with the Metika. That's all. And very interestingly, I woke up at 3 o'clock and absolutely there was no pain, no swelling. I was searching for the mark of incision. There was no evidence of any incision, but it was a very spontaneous reduction, and I could free jump and so on within a moment after 3. Now, whether you call it as superstitious or anything else, that's another issue. But it's something which I have experienced. So something, when you are at a level of extreme frustration, there is something like a superpower which guides you. Maybe in terms of that intervention, maybe that superpower which I refer to in the context of that CBD obstruction pathology, that T-tube obstruction pathology, there again something has saved. So when we have that strong commitment as such to the job, and when we have that kind of an urge to save the interest of that, there is something like a superpower which guards us, which protects us. That's all the point. I think Dr. Srijit, your request is met with. I hope so. Is it? Right, sir?
Yes, sir. Yes, sir. More than 200%, because
Okay.
this recording is for the future generations also.
Okay.
And I thought it's open. Yeah, it's important that the current generation, the future generation, keep their minds open to the idea of a pratyakshami alpam, that kind of context. So it was very important that we kind of graduate from the physical to the seemingly non-physical. And I'm
Okay.
very thankful that you allowed us to listen to this.
Okay, fine. I think uh, I think
Uh,
now it's time to conclude. I think, is it okay? Right.
uh, yes,
Fine,
sir.
sir.
Yeah, actually, you have actually, very thoroughly got us into a full understanding of the entire domain of the way the oncology can be practiced. And I wanted to just convey to the audience here that I have been personally allowed to stay in two OPDs of sir, two occasions, and what I have personally realized that the efficiency and clarity with which sir handles OPD is just like eye opener. I strongly believe if anyone is lucky and permitted to visit before starting post graduation or any practice, sir literally single handedly handles all the departments of OPD, right from the booking to the dispensing to the doctor part to the pharmacy part. Like he's just handling it with easily 100 plus OPD per day for so many years. And I am taking the liberty without seeking permission from sir that sir obliges to reply to people who are not even directly known to him. Like I am his student. I am not directly his student. To call myself a student will be a big claim, and I think it will be impolite. I mean, we will never grow up enough to claim that big title. However, most of us, the doctors in Kerala and outside, we look up to sir to be guided when we are absolute darkness with challenging cases. And at this seniority, sir makes sure that he obliges to reply to nearly 25-30 emails to doctors like me
Nah.
on a nearly daily basis.
Hello, yes,
And he
I'm fine.
obliges even to reply on WhatsApp. He lives a very astute life, and where he's up by 3:30, he's already done his physicals, and he's studying. And he always tells me, and of course everyone, that he prefers to be more modern than the modern doctors, and it is just unbelievable level of rigorous, regimental, disciplined, academic, professional, personal life he lives, and daily crossing 100 OPDs, and including Sunday. I mean, this unbelievable way he does a practice, and the most, I mean, everything is great about his practice, but the most amazing that you would believe only if you see, only if in OPD, is that the cost. Cost is just unbelievably low. It is seeing is believing. I mean, many of you may think I'm exaggerating. Not at all. I've seen myself. A month you won't pay more than 400. If you are a patient of Sir, whether you come in Audi or a Benz car, doesn't matter. You go in a simple bicycle, doesn't matter. Even if whatever you are, if you take medicines or consult him for 1 month, you are hardly crossing 450 rupees. I think it's 400 actually. I mean, definitely not 500. Definitely not 500. You don't pay more than that. I mean, that economic feasibility and that economic precision with the clinical accuracy and the effect is something that I would always dream in my lifetime to become a pan India moment for doctors to practice such low cost and such clinical precise efficacy. And that can definitely lead us to get into the lower middle class. And if we get into the lower middle class in a very effective manner, then we had it. Then the public would never forget us, and they would always sustain us. And I think what is happening as a bad luck to Ayurvedic fraternity is exuberantly high cost of medicines, and the availability of the faculties become extremely unreachable to the common mass. We all know it is the lower middle class or the middle class that wins elections for any government, not the upper middle class, not the upper class. Oh, sorry, the upper financial class. Same way, Ayurveda would sustain only through the economically poor and the less privileged people. So, Dr. Mudal Sharma sir's methods are such proven methods, which is like thousands of cases and patients are taken care of, not more than 36 medicines. Sir, please correct me if my numbers are wrong, but as much I remember, sir had directly told me not more than 36
Okay,
type of
that's
medicines.
right. That's true.
Uh, yeah, and wide variety of cases. We are not talking of simple cold and flu, definitely not. We are talking from a cold to cancer, and all complicated, all lost hope, multiple. I would also, I wouldn't say I'm suspecting, but I had personally sought the guidance on that. I did say to sir, is it only your medicines, or is there any X factor working through you? And he was, I think he was humble enough, or I don't know if sir was diplomatic enough. Sir was smiling and he said, no, no, nothing like that. It's the medicines working, not me. So, well, I would just believe and accept whatever sir has said. But deep inside me and the students of his students, like, we do believe that there is an extra factor in him. That's what we believe. But maybe, that's because of his accumulated karma as a karma yogi in Ayurveda, the long standing experience. He has created a generation after generation of effective ideas, and our community can never thank him enough by words or by deeds. I think this is what I wanted to reserve towards the end at least. And sir, we can't thank you enough for so much of time and the clarity. If any one of you wants to contact him, I would suggest email, and you would be surprised at the precision of his replies, like surgical precision, and the brevity and the clarity is just unbelievable. So I think email ID is already shared. We know somebody has asked for a phone number. I'm not daring for that. The email, you will definitely get reply, and that's what sir does every day. 25 to 30 emails of literally unknown people to him who are not directly in the country. He just obliges and makes life easy for the doctors and the terribly suffering patients also. I think Dr. Rashmi, anything from the Sitaram faculty, anyone to say concluding remarks, or else we should make sir free. I mean, we have already encroached more than 2 hours of sir's time, and this recording is anyway going to be shared with many people. And just to let everyone know that we are constantly bringing out the typed version of the YouTube classes that has already taken. So myself and my student Dr. Sharol Rashid, we are constantly bringing out in the Telegram group